In this presentation, we're going to quickly review the ureter and the bladder, and then we'll talk about some clinical correlations and applications to things we've talked about in the urinary system. Here, not so much to be tested on for the course, but just to give you an appreciation of how the kidney is involved in homeostasis and things that might go wrong. So this image on the upper left is a profile of the ureter. It's the proximal region of the ureter, and you can see an inner longitudinal layer of smooth muscle and an outer circular layer of smooth muscle. You can see the lamina propria here, the lamina propria of course being connective tissue, and here the mucosal layer, the transitional epithelium. This region of the ureter, there's also an adventitia. This is a higher power view of the mucosa of the bladder, and the mucosa of the bladder would look very much like the proximal region of the ureter. It would have a transitional epithelium. You can see these large dome-shaped cells. This transitional epithelium is impermeable to water and to salts. Here's the distal region of the ureter, and looking at the higher power, you can see inner longitudinal layer of smooth muscle, a middle circular layer of smooth muscle, and then an outer longitudinal layer of smooth muscle. So in the distal region of the ureter, there are three smooth muscle layers, and it's always arranged as an inner longitudinal, middle circular, and outer longitudinal layer. A higher power view of the epithelium again, noting the transitional epithelium, the large dome-shaped cells like so, and here you can even see a cell that's binucleate. And you can see the adventitia in the low power view. The male urethra is fairly long, maybe 15 to 20 centimeters. There's three major components in the male urethra. The prostatic urethra is entirely within the prostate gland in its transitional epithelium. The membranous urethra passes through the urogenital diaphragm. The epithelium here can be stratified or pseudo-stratified columnar epithelium. There is an external sphincter of skeletal muscle in the urogenital diaphragm, and then the penile urethra, the longest component of the male urethra, is entirely within the corpus spongiosum of the penis. The epithelium in the penile urethra is very highly variable. The female urethra is much shorter, only about 5 centimeters. It consists of transitional epithelium near the bladder. There may be some stratified squamous epithelium. There may be pseudostratified columnar epithelium. But a characteristic of the female urethra especially is the epithelium is highly variable. There is skeletal muscle in the external sphincter, and there are mucus glands of Ureter that are along the entire lengths of both the male and female urethra, and sometimes you can see those in histologic section. I want you to have just some general appreciations of some clinical correlations in the urinary system. Now, first of all, lobated kidneys. In the fetus, human kidneys are lobated. You can see actually deep clefts in the fetal kidney. These can sometimes be retained at birth and in adults. This is not a pathological condition. Polycystic kidney disease is a relatively serious situation. You get anomalous development that will lead to cysts in and on the kidney, and about 10% of chronic renal failure cases are thought to be related to polycystic kidney disease, and you usually see chronic renal failure catching up with patients somewhere in their 5th decade of life. There are autosomal dominant and autosomal recessive forms of polycystic kidney disease. The autosomal dominant forms are the more common forms, and there are 3 different genes that relate to the autosomal dominant polycystic kidney disease. As you can see here, polycystic kidney disease gene 1 codes for polycystin 1, polycystic kidney disease gene 2 codes for polycystin 2, and not surprisingly polycystic kidney disease gene 3 codes for a gene called nephrocystin. I give you the chromosomal loci of these genes, not important that you remember that right now. Polycystic kidney disease 1 is the most common, accounting for something like 85% of the cases. Polycystin is a calcium channel membrane protein that appears to be associated with the primary cilia on principal cells. The autosomal recessive form of polycystic kidney disease is less common, and it's actually more severe in many of the children that have this die in childhood. The gene maps to chromosome 6. The gene product is fibrocystin. The gene itself is a polycystic kidney and hepatocyte disease gene. And fibrocystin is a membrane protein that thought to relate to cell interactions and cell signaling, among other things. Glomerulonephritis is an inflammation of the glomeruli. As you might expect, you'd see proliferation of podocytes, endothelial cells, and mesangial cells. Glomerulonephritis is often secondary to a streptococcal infection elsewhere in the body. Immune complexes can build up and be deposited in the glomerular basement membrane. This can lead to reduced glomerular filtration rate. Glomerulonephritis could be an autoimmune disorder. You see hematuria, proteinuria, and oliguria, and glomerulonephritis, if left untreated, can be fatal. Chronic renal failure can be caused by a variety of conditions. We just mentioned polycystic kidney disease, but chronic renal failure is significant in that it can lead to reduced blood flow and hence reduced filtration. Over time, with chronic renal failure, you get loss of nephrons. The remaining nephrons will try to compensate. Over time, you may see secondary conditions like glomerulosclerosis. Chronic renal failure is often part of the sequelae of diabetes, of hypertension, and of atherosclerosis. Diabetes insipidus, we don't talk about it here. You may talk about it a little bit in physiology, but that can lead to dehydration and polydipsia. There's something called ADH sensitive or central diabetes insipidus. In this case, interestingly, there's destruction of the supraoptic and paraventricular nuclei in the hypothalamus. As a result, you have loss of ADH, and the kidney cannot concentrate urine. There's ADH insensitive or nephrogenic diabetes insipidus. Here, the kidney tubules don't respond to ADH. ADH itself is present, but the kidney tubules don't respond. There does not seem to be a single cause on a population basis, but chronic essential hypertension is thought to be caused by excessive secretion of renin by the G cells. Now remember, with normal levels you'll get increased activity of angiotensin converting enzyme. So with too much renin being produced, you're going to get hypertension. One of the ways to treat this is with ACE inhibitors. And of course you'll learn about other modalities for treatment in pharmacology. Urinary incontinence, you have loss of voluntary control of the external sphincter muscles in the urethra. This affects the elderly, and it affects women more than men. Prostatic problems clearly are issues for older gentlemen. You can have benign prostatic hyperplasia, or you can have prostatic carcinoma. Prostatic problems can lead to potentials for post-renal failure, and you'll talk about this a little bit more in your physiology course. And of course, kidney stones, nephrolithiasis. You have uric acid accumulation, calcium salt accumulations, and magnesium and ammonium acetate accumulations. Something I'd like to just mention in passing here, because remember that collagen type 4 is a significant component of the lamina densa in the glomerular filtration barrier. And so there are various pathologies that are associated with collagen type 4. So for example, good pasture syndrome, antibodies to collagen type 4 will be built up in the glomerular basement membrane that can lead to glomerulonephritis and hemorrhages. You'll see pulmonary hemorrhages because collagen type 4 is also found in the lungs. Alport syndrome is an X-linked recessive syndrome. You get irregularities in the glomerular basement membrane, glomerulonephritis leading to renal failure. You can have hearing loss and ocular symptoms. In Alport syndrome, these X-linked recessive mutations are mutations in one of the collagen genes, here the collagen 4A5 gene. And then there's another type of mutation, benign familial hematuria. This is a dominant mutation in collagen 4A4 genes. Again, I'm not going to expect you to know this for our course, but it's just to give you an appreciation of things that might go wrong. Congenital nephrotic syndrome, you may have an absence or non-functioning of the filtration slit diaphragm. This can be caused by mutations in the nephrin gene, and right now something like 70 different mutations have been described, and many of these mutations can be lethal. To remind you, mesangial cells function to maintain the integrity of the glomerulus. The mesangial cells produce a mesangial cell matrix, which is going to contain fibronectin, various collagens, and other extracellular matrix proteins. The mesangial cells, as we said, function to clean the basement membrane. They can take up glomerular basal laminar material for turnover and for phagocytosis. The mesangial cells contain contractile cytoskeletal elements, so as the mesangial cells contract, they may regulate or modify blood flow through the glomerular capillaries, therefore affecting glomerular filtration rate. The mesangial cells can respond to substances like endothelin, which can cause vasoconstriction of the afferent and efferent arterioles. The mesangial cells may respond to angiotensin II. Mesangial cells may also release various cytokines that will play a role in inflammatory responses. This slide is certainly beyond the scope of our course, but I just would like you to understand that immunologic complications related to mesangial cells can be manifest with a variety of renal pathologies, and likewise, this slide is also beyond the scope of our course, but it will highlight for you differences between acute glomerulonephritis and rapidly progressing glomerulonephritis. The acute glomerulonephritis is reversible. This is proliferation of the mesangial cells. They will respond appropriately, and then as the situation resolves, the mesangial cells will stop proliferating. On the other hand, rapidly progressive glomerulonephritis is a proliferation of the epithelium, both the epithelium of Bowman's capsule and the endothelial cells that make up the glomerular capillaries. This proliferation of endothelium and the epithelium of Bowman's capsule essentially compresses the glomerular capillaries. That leads to a reduced glomerular filtration rate, and it can lead to rapid renal failure, because if you are restricting the flow of blood through the glomerular capillaries, you're also then restricting blood flow through the peritubular capillaries and vasorector, so you're going to essentially affect the nephron and collecting ducts downstream. Here is a histological overview of the prostate gland, and it's just highlighting the different zones of the prostate gland. Here you can see the urethra, and here you can see ejaculatory ducts. This transitional zone of the prostate is where you get benign prostatic hyperplasia. You see this in the transitional zone and sometimes in the central zone. The peripheral zone out here is where you tend to get the prostatic carcinoma forming. So this is important when older gentlemen come in to do a regular prostate exam, because in this peripheral zone you get the carcinoma. The urologist can often tell on a digital exam. You can feel irregularities in the prostate.